Hello friends, this is Dr. Deepthi Variku, HOD, Department of Physiotherapy, Dolphin PG Institute of Biomedical and Natural Sciences. Our today's topic is weaning. Weaning from the ventilators. So we'll start off with what is weaning. So first thing is the weaning. Weaning is the process of withdrawing the patient from the mechanical ventilator support and transferring the work of breathing from the ventilator to the patient. Weaning is the disconnection from the ventilator. For some patients it's very easy, others need a protracted period of weaning with presence of lung disease or after long-term ventilatory support. This period includes a trial of spontaneous breathing through the artificial airway during which the patient is assessed or extubated. Before weaning, the patient should have recovered properly from the acute phase of the disease, leading to mechanical ventilation and to be able to assume adequate spontaneous breathing. Weaning is gradually started after evaluating the patient's clinical condition, pulmonary and cardiovascular status. Depending upon these parameters, patient may be given spontaneous breathing trials or the patient could be extubated. If spontaneous breathing trials are unsuccessful, patient is taken back on partial ventilator support or pressure support and gradually the setting is reduced and the SBT is again repeated. SBT is spontaneous breathing trials. The period includes a trial of spontaneous breathing through the artificial airway during which the patient is assessed or extubated. There are various difficulties while we perform weaning on the patients. First of all, let us see what are the ventilator modes which are used for weaning. First is conventional mode used. In this we use pressure support ventilation, continuous positive airway pressures, synchronized intermittent mandatory ventilations. Then there are advanced modes used in which we use volume support, volume assured pressure support, mandatory minute ventilations, airway pressure release ventilation and automatic tube compensations. There are various criteria which are followed for weaning. Weaning criteria are used to evaluate the readiness of a patient for a weaning trial and the likelihood of weaning success. In this we have to make sure that we look out for difficulties in weaning, which could be due to damage of inspiratory muscles which occur due to the lung diseases or the patient's fear for suffocation. So what are the criteria? First, the clinical trial, then the ventilatory criteria, oxygenation criteria and pulmonary reserve and measurements. So clinical criteria क्या हैं? Clinical criteria are resolution of acute phase of the disease, or if the patient is having adequate cough, there is absence of excessive secretions or cardiovascular and hemodynamic stability. So these are the clinical criteria. Then ventilator criteria. Ventilator criteria may we need to see the parameters of the ventilators which should lie between these criteria. For example, we have to check for spontaneous breathing trials, PaCO2, the vital capacity, the spontaneous VT, spontaneous F and the minute ventilation. If this all is satisfactory in ABG, then weaning could be continued. Then there is oxygenation criteria in which we check PaO2 without PEEP and with PEEP. And then saturation of oxygen, partial pressure of oxygen, all these gradients had to be checked before we start the process of weaning. Then there is pulmonary reserve and measurements which we need to check, like vital capacity, maximum inspiratory pressure, static compliance, airway resistance. Before weaning, these all parameters and criteria should be checked. Then there is weaning procedure. Now, weaning could be very successful if we follow the procedure very properly. So, procedure includes spontaneous breathing trials, pressure support ventilation, synchronized mandatory intermittent ventilation SIMV, which is not recommended alone but along with the upper two processes. So weaning procedure, will start off with SBT, spontaneous breathing trial. It is an evaluation of a patient's readiness for weaning from mechanical ventilation and extubation. SBT is the major diagnostic test to determine if patient can be successfully extubated and weaned from the mechanical ventilator. Spontaneous breathing may be augmented with low level of pressure support, CPAP or automatic tube compensations. It may last up to 30 minutes. So we have to make sure that we know that this is done properly. This is the procedure of SBT and the steps we follow in it. First, we can use T-tube. CPAP should be maintained or automatic tube compensation. Let the patient breathe spontaneously. We can do it for 30 minutes. We may use low level pressure supports to augment spontaneous breathing. Then again assess the patient. If patient tolerates the step 4 very properly, then consider extubation when blood gases and vital signs are satisfactory. If you think that it is necessary to return patient to mechanical ventilation, that could be followed. If there is SBT failure, again then you can stop the weaning process and go for ventilators. There could be rapid shallow breathing. If there is rapid shallow breathing, it is mainly used to evaluate the spontaneous breathing pattern. The rapid shallow breathing is calculated by dividing the spontaneous breathing frequency by the average spontaneous ventilatory training. Absence of rapid shallow breathing is defined by a F upon VT ratio of less than 100 breaths per minute per liter. It's an accurate predictor of weaning success. So we have to make sure that this is also followed properly. When the RSB1 is greater than 100, it correlates with weaning failure. That means we have to stop weaning. Now weaning using PSV. PSV may be used in conjunction with spontaneous breathing or SIMB mode. Depends. We start PSV at level of 5 to 15 centimeter of H2O to augment spontaneous ventilation until a desired ventilation is reached. Decrease pressure support gradually so that you reach proper intervals of that is 3 to 6 centimeter H2O. If patient tolerates your step 3, that is you are decreasing the pressure support and he is maintaining it properly, consider extubation when blood gases and vital signs are satisfactory. Again I am repeating, if it is not satisfactory, weaning could be unsuccessful. Now if we use one SIMV mode, which is not recommended alone, so reduce SIMV frequency by 1 to 3 breaths per minute. Monitor your saturation of oxygen, obtain ABG. Reduce SIMV frequency further until a frequency of 2 to 4 per minute is reached. This may take only hours for patient with normal cardiopulmonary functions, but it may take days for those who are under abnormal functions. If again patient is able to tolerate 3-step, weaning could be achieved. If not, your weaning could be failure. So this is the basic criteria which we are using for weaning after the patient is on mechanical ventilation. Once again, I will tell you the method. The explanation of the procedure should be given to the patient. Gradually reduction of ventilator support can be achieved by decreasing the frequency of breaths during IMV or SIMV. Reducing the pressure during the assist control made. The patient sits in the chair with arms rest on sit upright in the bed. Humidified oxygen or CPAP is prepared if oxygen is connected by a T-piece. Extension tubing of 60 cm long should be attached to exit to prevent entertainment of room air in case the patient's inspiratory flow exceeds the system flow rate. The air is then suctioned. Then the patient is disconnected from the ventilator, given oxygen, or you can use CPAP as comfortable. Encourage the patient to breathe and monitor for signs of labored breathing. You have to see whether the work of breathing is increased, if there is anxiety, if there is desaturation, if there is fatigue or any drowsiness. If there is difficulty in weaning, that may be due to undetected diaphragmatic paralysis, anxiety, or inspiratory muscle fatigue. So if something is like that, then you have to prepare the patient again for ventilators. Preparing with inspiratory muscle training or incentive spirometry is helpful in appropriate patients. Weaning is success. This is said when there is absence of ventilatory support for more than 48 hours of extubation. Weaning is in progress is said when there is an intermediate category. It is an intermediate category for patients who are extubated but continue to receive ventilatory support by non-invasive ventilators. And we say weaning is failure of spontaneous breathing trial, or the need for re-intubation within 48 hours following extubation. Now, weaning failure, early signs of weaning failure may include tachypnea of the patient use accessory muscles, and there is paradoxical abdominal movements, there is dyspnea, chest pain, chest and abdominal asynchrony, or other signs like patient may have anxiety, patient may show there is dilation of pupils, there are lots of other signs which you could feel that patient is not comfortable with weaning. Then we need to see whether the patient, what are the conditions that may hinder a successful weaning. So patient, there could be pathological conditions which will hinder your weaning, like fever, infection, renal failure, sepsis, sleep deprivation. There could be cardiac or circulatory defects like arrhythmia, blood pressure either high or low, cardiac output either high or low, fluid imbalance, anemia, dysfunction hemoglobins. There could be dietary acid-base electrolysis abnormalities which could hinder your weaning, like nutritional or caloric deficits, acid-base imbalances, electrolyte imbalances. These all could hinder your weaning. The patient could have problem in weaning. So what are the basic causes? As we all know, the basic causes could be increase of airway resistance, decrease of the compliance of lung, respiratory muscle fatigue. These are the basic causes for failure of weaning. So we have to make sure that these causes are maintained properly while the weaning is done. Increase the airflow. Other strategies for decreasing airway resistance has to be made, like periodic monitoring of the ET tube for kinking or obstructions by secretions or other devices attached to the ET tube, such as continuous suction catheter, heat, moisture exchanger, or end-tidal CO2 monitor probe. Endotracheal suctioning to remove retained secretions, and use of bronchodilators to relieve bronchospasms. These are the basic things. So for decrease in compliance, which we could see, there are various types of compliances, like decrease in static compliance, or there is decrease in dynamic compliance. These are the clinical conditions which may hinder the weaning by decreasing the compliance. Now, respiratory muscle could also go for fatigue, which may hinder weaning, and the causes could be low lung or thoracic compliance, muscle disuse, mechanical ventilation induced oxidative stress, inadequate oxygen delivery, insufficient nutrition, electrolyte imbalance, especially hypokalemia and other conditions. So we have to make sure that these things are previously monitored before we go for weaning. Then now let us see when we say the weaning is successful. When the maximum ventilatory reserve is present and the optimal nutritional status, fluid, metabolic, cardiovascular is achieved by the patient. Patient has a good sleep, patient has minimum sputum, maximum ability to cough. So then we move to terminal weaning. The terminal weaning is defined as withdrawal of mechanical ventilation that results in the death of a patient who is terminally ill or brain dead. This is different from euthanasia or mercy killing, so we have to make sure about this. Ethical and moral concerns and legal issues arise before ending mechanical ventilator support. So this is mainly done to those patients who have a legal concern for this. Only done after detailed discussion with the family members, and when they say, okay, now we don't want, the patient is suffering a lot, then the terminal weaning could be done. In India, terminal weaning only is legislated in brain dead or patients in persistent vegetative state. as still there is no clear legislation, such a move requires the permission of High Court for terminal weaning. So when we wean, the successful weaning of the patient from ventilator is when the patient is removed from ventilator and he can breathe it properly. But terminal weaning is when the patient is declared dead after the weaning procedure. Thank you. Hope you all had good time today and you understood about weaning. If there are any doubts or any confusions, they are welcome. Thank you so much. See you in my next class.